TopMedTalk.
Well, hello and welcome to TopMedTalk. I'm Desiree, Chappell, your host, and we are here in Denver, Colorado for the annual meeting of IARS, the International Anesthesia Research Society, the AUA, Association of University Anesthesiologists, and SOCA, SOCCA, the Society of Critical Care Anesthesiologists. It has been a fabulous meeting. We've had lots of great conversations. Now I'm joined by my co-host, Monty Mythen. Hello, Monty.
Hey, Desiree. Very good to be here.
It is good to be here. Monty, for those listening that may not be familiar with these three organizations, can you just give just a little bit of background on that?
So the AUA and SOCA, as far as I understand it, are the younger of the two organizations. The AUA with the U in the middle being much more university-based, so we can think about the residency programs in the USA there. You can get some other inputs on that at the moment. And SOCA being the critical care anesthesiologists. But at the heart of it, not to undermine the other two organizations, is the International Anesthesia Research Society that is celebrating its 100th anniversary. Three great organizations coming together in one place to deliver a great meeting, and we'll go into more of that in a moment.
Yes, we have seen friends we have not seen in a long time, those in the greater world of academia, presenting some wonderful research that they've been working on the last several years. It's been absolutely fantastic. Two folks that we're excited to catch up with that have been presenting over the last year on some research that they've been doing are our friends, Rick Dutton from US Anesthesia Partners and Josh Lumley from NorthStar Anesthesia, both chief quality officers at their organizations.
Okay, so I am US Anesthesia Partners chief quality officer. I am a recovering academic, maybe a once and future academic, since I just moved back to the University of Maryland system from Dallas. And I'm continuing to work with USAP, but I'm taking on a new project as a site chief at Capital Region Medical Center just outside DC.
Josh, tell us a little bit more about your role and your work that you've been doing.
Yeah, anesthesiologists, clinical anesthesiologists in the Columbus area. So that's where I get my clinical time in. And I'm also NorthStar's chief quality officer.
My partner.
Yes, my partner. I work with a outstanding colleague, Desiree Chappell. Yeah, I've really focused on three main areas there. So reporting our clinical quality metrics to CMS and third-party payers, trying to drive standardized clinical techniques across our footprint, and then continuing to drive the needle on patient safety across our clinical sites.
Yeah, absolutely. Well, guys, we did talk last year at ASA. We presented then some work that we've been doing over the last year. Rick, give us a little high level of, where we've been, and then we presented today. So talk a little bit about that.
Yeah, through your predecessor, Brian Woods. Yeah. He roped me into this, but he pitched me now a couple of years ago on a collaborative between our large private practices to pull data to look at pragmatic questions in anesthesia. And it's sort of a unique opportunity to build a research collaborative outside of the normal university structure, somewhat enabled by the information age and the ability to move data around more readily now and capture more. But as this project's continued to mature, it's been a wonderful opportunity for us to collaborate on patient-relevant anesthesia quality improvement. So,
yeah. Josh, the value of this type of work that we are working together on, just elaborate a little bit more on that for us.
In our line of work, we have anesthesiologists and nurse anesthetists, let's say nurse anesthetists ranging from mid to late 20s all the way up into their 60s, anesthesiologists that are practicing, early 30s up until their 60s. And you want to keep people engaged and driven and continuing to advance their clinical skill set. And this is one area that for me is a tremendous opportunity for us to change clinical practice amongst our clinicians, to have them feel like, wow, I'm learning something new. This is how I need to adapt my practice to really take better care of the patients before us. So much of what we do within our departments of anesthesia to improve clinical quality and patient outcomes is really codependent or dependent on other clinical specialties and clinical lines to be involved with us, whether that's post-op nursing, post-op pain control, our surgeon colleagues, our internal medicine colleagues, hospitalists that are there on the floor, pre-anesthesia testing units. But what we're talking about here is largely wholly dependent upon anesthesiologists and nurse anesthetists in the operating room making clinical decisions that have a meaningful impact on the patient afterwards. And I don't want to go as far as say it's a game changer, but it is one of those few areas that our sphere of influence is pretty profound on what we can do for the patients long after surgery.
We've presented this a couple times, ASA, PGA. And for those that might not have heard, Rick, big picture, what were some of the findings that we had?
So we pulled a bunch of real world data, just sort of harvested our clinical cases for a 2-year period, cases where we had detailed vital signs. Our initial question was just, what is the incidence of intraoperative hypotension? We chose to use the ASA's definition of that, which is a federal quality measure. So it was an easy one to align around. So mean blood pressure of 65 or lower for a cumulative 15 minutes during the course of the anesthetic. That's the measure. And we were able to do this with funding from Edwards to accumulate the data. Both NorthStar and USAP sort of threw it voluntarily into the bucket. Mm-hmm. Edwards funded Mathematica, a contract research organization, and a very good one, who had developed the ASA's original measure, to take that bucket and turn it into meaningful information. So bottom line, incidence of intraoperative hypotension was 29% in our sample of 127,000 cases, which is almost exactly what it has been consistently in the academic studies, the Cleveland Clinic, MPOG, other groups that have looked at it. It's around that same number. Interestingly, in our data, a little more common in what we would have perceived as lower risk patients. So younger, lower ASA physical status, ASCs versus hospitals, actually a little more hypotension than we would have than in the sicker patients. And we still don't know if that's because we're naturally giving those groups more anesthesia, if we care less about treating the hypotension because we perceive the risk is lower. We don't really know why that is, but it was an interesting finding.
Different type of anesthesia. Heard that one today.
Exactly.
Yeah, sure. Josh, kind of digging a little bit further into that, we did notice, there was a lot of variation by clinician. Now, some people, we've talked a little bit about risk adjusting versus non-risk adjusting. Dive into that for a minute.
Yeah. So, what we did in our non-risk adjusted or unadjusted data, we found the percentage, the incidence of hypotension across the 530-ish anesthesiologists and nurse anesthetists, ranging anywhere from 3% to 74% of a clinician's cases. So, dividing that out, we have a few clinicians who are on the far left of the curve who have less than 5% of their cases have clinically significant hypotension. And then on the far right of the curve, we have clinicians that are 2/3, 3/4 of their cases have episodes of clinically significant hypotension, MAPS less than 65 for 15 minutes or less. Then when you kind of do a look at the observed versus expected ratio. So
yeah, because a lot of people would say, sorry to interrupt you. A lot of people say, well, it's just my patient. It's not,
my patients.
It has nothing to do with me. My patients are super sick. We take care of the sickest, oldest patients everywhere.
That's right. So then we did a subsequent regression analysis where we tried to remove the factors that a clinician could not control. So that would include BMI, that would include age, that would include ASA classification, et cetera, all of which, you can't control, to try and get apples to apples comparison between individual clinicians, anesthesiologists, and nurse anesthetists. So then we overlaid that on what we thought. We said, amongst all of our 100,000 plus cases, what is our expected incidence of hypotension? And then what is our observed? And so the metric for that was right at 1 would be where we expected the average to be. And then less than 1, you have less intraoperative hypotension, more than 1, more hypotension. When we did the analysis and we looked at that, what we found was the types of patients that people who had less hypotension and clinicians who had patients that had more hypotension, their patient comorbidities, their patient mix was essentially almost identical across the board. In fact, the folks that had more hypotension than expected actually had younger patients, patients with a lower ASA classification, and more commonly were patients that were in the ASE.
What we're all holding our breath for, which you brought up in the great presentation we just saw on the main stage here at the IARS, is the link with outcomes. Because when we feed back to the providers, they will understandably give the same answer that you just heard proposed. My patients are hard and my outcomes are great, et cetera, et cetera. And we're all anticipating that. I'm sure that's where you're going to go. Now, when that happens, there's always a possibility that the distribution is not going to be as anticipated, which is an important component of it. So when we've looked at fluids in the past, for example, it's turned out the outcome has turned out to be U-shaped in the same way as the Gaussian distribution is bell curve. Well, predict the future for a second, Rick.
So, very big picture, our biggest problem in anesthesia quality and honestly anesthesia science right now is our inability to connect process to outcomes.
Yeah.
So we really need to know what happens to our patients. Do they die? How long are they in the hospital? Do they get transfused post-op? Do they have renal failure post-op? And one of the things we're going to be able to do in the next layer of this project is start to connect some of those outcomes to the very granular and honestly over-interpreted vital sign and process data that we have right now. So just knowing what happens to my patient's creatinine for some large sample of patients is going to be hugely valuable to us. It will make us smarter. Now, what's my bet? Some patients it's going to matter and some it isn't. And that's what we're going to discover.
Josh?
I agree. Some it's going to matter to, some it isn't. But I think this is where it's a great opportunity for us to look at a whole host of metrics, lab values, and, just sort of patient experiences like postoperative nausea and vomiting. There's a whole host of things that we can look at in that postoperative period to kind of assess, is there an impact and how significant is it on a young patient? How significant is it on an older patient? And then overlay that also with that time-weighted average of hypotension that the patient experienced, during the case.
So how else are you looking at the data? Are we looking at the data? What can we interpret?
Before they answer that question, Desiree, if we take the variables that Rick proposed, for example, why is it difficult?
Because we live in a Tower of Babel. And because we are sharply focused specialists. We have this professional myopia. I drop my patient in the recovery room and I have no idea what happens to them next. And until we have good passive feedback systems so that I will just sort of automatically know who had a creatinine bump, who got transfused, who got reintubated, who went to the unit, who died.
I'm going to now be the payer.
Yes.
You're competing for business. I'm the hirer. Why don't I want to know what your results are? Because I've got them.
You would like me to rebuild the entire United States healthcare system right now?
Yeah, Rick, can you do
it? I've been working on it for years.
The contract.
So I actually do have contracts with commercial payers around reducing readmission rate, for example. One of the ones I've been trying to get for 4 or 5 years now and would love to do is a 90-day opiate use. That one is uniquely suited to a payer contract because the payer is the one who knows if the patient is still filling prescriptions 90 days later. Nobody else in the ecosystem does. It's not in my hospital EMR. They may go to a different system or a different doctor, but ultimately Blue Cross or whoever is paying for that. And there's a variable. I mean, it's obviously a very hot topic. I'm sure you've had many TopMed discussions about that. I think our intraoperative practice or perioperative practice can have a lot of influence on that, but I can't connect the dots.
It's like the payers, they can't make the connection that what we do actually impacts care.
Well, in current state, that's correct. There are confounding factors, as I sort of talked about it initially. There are very few things that in a silo, our departments of anesthesia have a meaningful impact on. We are in phase 2 we have the possibility to find out or not find out, or find out that what we're doing, in management of intraoperative hypotension really doesn't have an impact. I'm hopeful that it does, to be able to clarify that to our payers and to be able to say, across these metrics, us intervening in a meaningful way in the operating room actually has an impact on the patient afterwards. And that's why you should care.
Yeah.
You've done that, right, Rick?
Yeah. If you want to construct the thought exercise, what I would tell Cigna, United, Blue Cross is, look, if I can, statistically speaking, prevent 5 of your patients from going on dialysis next year, what's that worth to you? And the number is pretty big, right? Dialysis patient versus non-dialysis patient from the payer point of view.
So it's like tens of thousands
of dollars difference on an annual basis. And so if I have data, literature, practice that says we reduce our intraoperative hypotension rate, we will, in a large statistical population, remove 5 cases of dialysis from our outcomes, I ought to be able to sell that to the payer. As Josh said, right now, they don't believe that we can influence that. So one of the really important bits of this research is to show that that is something we can control if we lean into it and mitigate our practice.
And Josh, are we team anesthesia prepared to own that? Or do you think the ownership of that will differentiate the very high quality groups from the other groups?
Well, I mean, yes and yes. Hand raised high. We are ready to own that. And then it is going to be a distinguishing clinical quality factor beyond just how much does your anesthesia department cost to run? And are you going to help me get cases through the operating room as fast as possible? Then the third component is clinical quality actually really does have a big bearing and a big impact on how my patients do or how our healthcare system functions. So I need to consider that third leg of the stool, which is clinical quality.
Yeah. So some of the things we presented today was, what are we doing to work with the data that we have? Where else can we go?
Yeah. So, and we just had a panel on it, so we got some more suggestions from the audience, which was sort of cool. One of the obvious ones is taking apart the definition of intraoperative hypotension. Yeah. Right now, as I said, 65 for 15 minutes total. Is that the right definition? Or is that the one that correlates most strongly with the outcomes? And that's in phase 1, just looking at the demographics. One of the things we're doing now, and I hope Anna talks about this, is looking at when did that hypotension occur? Did it occur before the surgeon dropped the knife? So it's mostly related to anesthetic induction. Or did it occur later and is mostly related to bleeding or too much forain or something?
Yeah.
And that probably matters because it probably affects what the right treatment is for fixing the hypotension.
I'm very excited about where this is going next. It's frustrating to know that we are not able to capture our full set minus the cardiac cases, the transplant cases, the true exclusionary cases. We're not able to capture all of our cases just simply because so many of our locations are still on pen and paper and don't have an AIMS platform or have, frankly, a very rudimentary EMR. And so, it'd be wonderful if each of us is capturing our millions of anesthetics that we do annually to be able to really take a true deep dive on types of cases where this presents, locations, clinician-specific factors, where it occurs during the case, things like that. We are still going to be able to explore that, but we're just going to be a little bit, at least on the NorthStar side, a little bit hamstrung because while it is going to represent hundreds of thousands of cases, it's truly going to be less than 20% of the cases that we do.
Yeah. Josh and I have been presenting the IOH data to our teams. We've had a clinical leadership conference. We have been going around our sites. We're trying to get this into the end user, into their hands, just the information. I feel like we live in a little bit of an echo chamber. We talk a lot about IOH. We're like, it's bad. This is happening. I have found when we talk to our colleagues that though they feel it's something important, they still don't quite get it. And they really want to know what they do about it. Rick, what has your experience been here?
Yeah. So you're probably a bit ahead of us there. I'm more at the level of generic education at this point, like intraoperative hypotension's bad. Here's why. And I haven't gotten to the level of specific education, right? Like when you see this, do that.
Yeah. Well, we're not quite there yet, but we're looking at it.
But my sense is we actually are making progress in this. And one of the interesting things about anesthesia is our ability to solve problems without a prospective randomized clinical trial. And sometimes that's because the problem we're looking at is very rare. Sometimes it's because the trial you need to do is very big or very complicated or whatever. But if you think about it, go back 20 years, we had an issue with intraoperative blindness.
Yeah.
Right. And it wasn't common, but it's obviously catastrophic. And every institution had one or two of these when you kind of looked around the United States. Well, it showed up in the closed claims data eventually is sort of where it came out in the US that this kept happening. There was a big discussion, a lot of bloviation about why, blood pressure, hematocrit, position, et cetera, et cetera. And without any controlled science done after that, the problem's largely gone away.
Yeah.
Just because we pretty much generically recognized it was a problem, and we probably do all of those things.
Yeah.
We keep the blood pressure a little higher, we're a little careful with positioning, we transfuse the patient a little earlier. And I see some of that happening with intraoperative hypotension now. I think my clinicians, just from the noise about it, we've gotten better. Opiate use is another one, right? Sure. Opiate use right now is a third of what it was a decade ago in anesthesia practice. And that, again, no controlled science there. It's just everybody sees it as a problem and we gravitate toward the solution.
Yeah. Josh, from your perspective and the experience that you've had, it seems like nudges do work.
I mean, obviously, it's purely anecdotal. It has really impacted the way I take care of my patients. Yeah. My willingness to intervene, frankly, the depth of anesthesia that I run my patients. And so that's an N of one. That said, I think overall, our clinicians that we work with have enough humility and emotional intelligence to say, I'm all about getting better. I really would like to know that I'm taking good care of my patients, either when armed with company-wide data that says, hey, 29% of our cases have this much hypotension. I don't have the next step, which is this actually changing the way you take care of patients? After we presented some of this initial data to our clinician leaders in the organization, there were a ton of folks that said hey, can I have this so I can present it at our next M&M and share it more broadly? So Rick, to your point, I bet the next go round that we have, I don't know if things are going to change with the data set from NorthStar and USAP, but it's in the ether, no pun intended. And I think that folks are starting to kind of adapt their practice accordingly.
Yeah.
You referred to it in the presentation, Rick, about unintended consequences. Based on historical experiences, we're probably going to see in phase 1, let's call it that, we're probably going to see less intraoperative hypotension. And it's probably going to occur two ways. It's going to occur in the way that Josh just described, monitor a little bit more closely, worry about it a bit more, give a little bit less anesthetic, be a little bit more generous with fluid, and judiciously use vasoactive agents. And then another group, it's going to happen the other way, which is start a phenylephrine infusion.
Yep.
Which means the net result will probably be 0 in phase 1. Sorry to be skeptical. And then phase 2 will be how can we unpick those two routes? Is that fair comment?
Absolutely. The potential for unintended consequences is high in this case because we may create more AKI through overzealous use of pressors.
Well, we've already seen that presented in the MPOG. I mean, I hate to call that out, but Toy's paper recently published saying that they were looking at IOH, trying to reduce it. They reduced IOH and then the rate of AKI go up.
It did. And to be fair, it didn't go up a huge amount,
right?
But it definitely didn't go down.
Yeah.
Right.
Which is my hunch is if you looked at separated the groups, you'd probably have, as I described, at the two edges, and a group in the middle that were roughly where they were before. So it kind of changed the flight patterns a little bit. And,
It also makes me think because, in MPOG, the clinicians receive their data. They know how much hypotension they have. They know what their rates of AKI are. In my mind, as I'm thinking in my quality brain of what do we get back to our providers that is something meaningful? I don't want to just give them the rate of hypotension not related to anything else in kind of solitude. I don't know. I'm just.
Yeah. So what we've done, obviously, phase 1 is just show extent of problem, that it exists, and that it is clinician dependent. Probably next phase is going to be where we do the deeper dive on depth of anesthesia, where it occurs during the case, types of cases, maybe where it presents. And then I think, phase 3 is where we or some other entity who kind of picks the ball up and runs with it is, okay, so then when and where to intervene and what to intervene with. To Monty's point, I mean, there is definitely some asymmetric risk with saying like hypotension is bad. Everybody willy-nilly needs to get treated with whatever you want to do, whether that's fluid or it's a phenylephrine drip. That's not without complications there. So it'd be great in phase 3 is what I'm calling it, whatever. The next step is where we're equipping our clinicians to say, this is the type of person you should intervene on and you should intervene with blank.
Yes. Gentlemen, thank you so much. Again, always a pleasure to sit down and hear more about what's going on in the world of IOH and our little project. Hopefully we can follow up here in the next, year, maybe at ASA and catch up, and maybe we'll be into that phase 2+3, wherever we are.
We'll get to 3.
We're going.
Absolutely. And phase 4 is going to be using AI to help equip our clinicians to make real-time decisions.
Do that for us. All right. So our next guest today, we just spoke with Rick Dutton and Josh Lumley from USAP and NorthStar Anesthesia. Our next guest, we have Wael Saasouh, who is an anesthesiologist from the Detroit Medical Center, and he is our director of research at NorthStar Anesthesia. Wael, thanks so much for joining us.
Thank you. I'm happy to be here.
All right, I got part of your title, so tell us a little bit more about what you do up there in Detroit.
I'm a full-time anesthesiologist in Detroit, and I'm affiliated with the 2 medical schools with the Detroit Medical Center, so Wayne State University and Michigan State University. I do general anesthesia over there. I do some obstetric anesthesia, and in my spare time, if I can call it that, I do research. And my position with NorthStar Anesthesia is more of under the Office of Clinical Quality, so it's more of a global national level research initiatives across the footprint of NorthStar.
Yeah, well, we just had a conversation a little bit earlier in the day. So if you want to check out more, do just type in Wael Saasouh, and it'll come right up. While you've been helping to lead this project that we were talking with Josh and Rick about IOH in a community setting. And we have now, it's in submission, right? We've submitted to several journals.
Yes, we have 2 publications that are being considered, 2 manuscripts that are being considered for publication, and we've had some positive responses so far. So we expect them to be published within the next few weeks, I would hope.
So while we took a broad look at this cohort of 127,000 patients and looked at the rate of IOH in that, but then we started to do a sub-analysis. Can you tell us a little bit more about that?
Absolutely. We separated all the patients where the cases were done in ambulatory surgery centers or ASCs, and we took a deeper dive, pretty much the same analytics that we did for the grand cohort, and we tried to see if there's any difference in incidence of IOH, the reasons for the IOH, or any variability among clinicians, along pretty much the same lines as we did with the bigger cohort. And we found similar things, slightly different numbers, but they set the same results, basically. So we had the majority of people were younger, a lot of them were healthier, and a lot of the surgeries were shorter, which is what you would expect at an ASC, because typically those are your joint replacements or your eye surgeries or your plastics, things that don't necessarily need a hospital admission the day before, or they don't need a prolonged postoperative recovery in the hospital. And then we were thinking, well, these are the healthiest out of our healthier patients in the bigger cohort. And typically we would think that they should be less hypotensive during surgery. Ends up being almost the same thing, if not even a little bit more hypotensive.
Yeah, a bit of a surprise, right?
Yes.
Monty, does ASC transfer ambulatory surgery center? Does that
I think
translate?
people would get it. I mean, broadly speaking, day case surgery, less than 24-hour stay, many situations go in and out the same day would translate. And I think most people's bias in that situation would be, as you say, younger, fitter, quicker procedures, less likely to have problems, and therefore possibly by as a result. And then less monitoring and less attention to details. A complicated thing to say, but you know what I mean.
And most of these patients come in the day of surgery and leave the same day of surgery, for the most part, I would say. I know some centers do a better job at it than others. They don't tend to be worked up as extensively as hospital patients. You don't get a consultant to come in to see the patient at bedside the morning of or the evening before. Some of them will have some workup done on a pre-hospital basis, but then the anesthesiologist sometimes doesn't get to see those patients until the morning of, which sometimes puts us in a bind where a patient is considered to be healthy just because we don't have evidence that they're not healthy. That's a tricky situation to be in, especially if we're seeing this much hypotension. And I'm sure we're seeing similar rates of some other complications that we're not paying careful attention to at the time.
So I want to introduce our last guest today. Last but not least,
thank you,
Anna Christensen. Anna, thank you so much for joining us.
Thanks for having me. So I'm a health services researcher. So I'm the research guru of the team. I'm not a clinician. I'm the director of health research strategy and analytics at an organization called Mathematica. And what we do is healthcare research, analytics, quality measure development, and health policy consulting. So I spend my time directing research projects and crunching numbers and working with clinicians to help you understand your data.
Yeah, well, you've done a fabulous job. We want to thank you so much for working and collaborating with us. You have definitely led us in a great direction. And working through the data, which we all know is a while. I think you said during the presentation, even if you have good data, it's still a challenge to work with data.
Yes, yes it is. We're glad to have Anna.
Yeah, absolutely. Well, Anna, you also were presenting today. Can you walk us through a little bit about what you were talking about at the presentation?
Sure. So I wrapped up the group of presentations talking about our future research and what we're planning to study and what we think is important to study next in the general field of intraoperative hypotension. And so I talked a little bit about some of the papers that we're going to be doing over the next couple of months. And some of the topics that we want to focus on include refining the outcome measure that we're using, which is the CMS IOH measure that's used in the CMS merit-based incentive payment system, which is a payment and reporting program that maybe many of your listeners might be familiar with if they're US based.
Now, Anna, on that, can we take a minute and just dive into that? So we had lots of great questions after the presentation. Really, really good. Trying to dig in and help us maybe ask some more questions. One of the things I think someone talked about was defining and looking more at that 65 millimeters of mercury as the threshold for hypotension or not, kind of, black and white. We all know that people have different, come in to us differently. And so, when you guys developed, because you were part of the original development team on Pre-Op 31, that original MIPS measure. How did you guys decide on 65? And do you think that that's going to kind of continue, or are we going to look at that in different ways going forward?
Yeah, how we picked the definition originally was we did a literature review. We looked at the body of evidence regarding when does patient harm start to accrue, what MAP values, and is there a threshold below which patient harm starts to rapidly increase. And there's a lot of literature, particularly coming out of Cleveland Clinic, and a nice paper by Saasouh et al. That shows the risk depending on what MAP threshold you're at. And basically what they determined was there's sort of an inflection point at a MAP of 65 where if you dip below 65, then harm starts to rapidly increase. That was the deciding factor for setting that threshold at 65. One of the other things we think about when we develop quality measures is really making them simple. It's not meant to be an individualized metric that, not every patient is going to be managed at a MAP of 65. But what we're trying to develop when we develop quality measures is sort of the floor. There might be patients who you want to manage at a higher MAP, but probably not a lower MAP. So we have developed this sort of binary measure of hypotension that works pretty well for a global population.
Yeah. Wael, did you want
and one of the questions after the session hinted at that, why 65 was picked and why not maybe a % variation from baseline. Mm-hmm. And we've talked about this on previous occasions, and there has been work to suggest that if you pick the 65 millimeters as an absolute threshold, you are more than likely beyond that 20% change from baseline for any patient. Mm-hmm. Most likely some patients, if you're at 75, you're still below that 20% change. Also, there's always a problem with the definition of what is baseline blood pressure.
Right.
So it's very tricky to decide that the baseline blood pressure is the one measurement we did just before surgery when the patient was anxious and not happy about being where they are. They might be in pain. They might be
not taking their blood pressure medications.
Right, they might have just had their IV inserted. So
yeah,
that baseline is a tricky concept.
Yeah.
So there is some work to suggest that simplifying it into a threshold based on current evidence works just as well, if not better.
Yeah. So Anna, I know that measure was looked at again, and it may be in the future. Do you think we're going to kind of stick with that 65, or do you think that there'll be more conversation around that?
Unless we see the literature change significantly and we start to, see different patterns of what blood pressure values are associated with patient harm, I think that 65 threshold is going to stay. Some of the things that will be modified potentially with the measure is refining the risk adjustment model and just making sure that we're controlling for as many patient and case characteristics as is feasible, just to make sure that what's left of what we're measuring is actual clinician behavior and clinician quote unquote quality, as opposed to what their case characteristics are.
And I know we get pushback. I've heard this a lot from our providers. We've heard this as we've presented this more and more about that risk adjustment.
Mm-hmm.
And it's just so hard. I can't remember if you said it or Rick said it, the limitation in data, especially for us in non-academic settings, to get access to that's really tough. So you can't go in and be very specific on the patient's, what's going on with them, the certain case types and things like that.
Right. That's right. And, if you were doing an academic research study, you might control for risk adjust for, tens and dozens of characteristics. But if you're calculating a quality measure and you want it to be applicable to a wide range of practices, you have to be practical. You have to pick what's feasible to measure.
And there are surrogates, right? So
That's right.
We previously were using ASA class, but now we're trying to dig a little bit deeper on surgical duration and some things like that.
That's right. The current risk adjustment model uses ASA physical status as a marker as a proxy for comorbidities. Comorbidity data is very difficult to access. Obviously, not every patient gets their usual care at the hospital where they're getting their surgery. So it's not like you can go back into their patient records and see what other comorbidities they have.
Yeah, absolutely. Monty, anything?
I was going to say we should remind ourselves that maintaining an adequate blood pressure, which we're talking about what represents the threshold of adequacy, is a fundamental standard anywhere and anyhow anesthesia is provided. So I think the fact that we're debating this, whether it's 65 or not, is an interesting variable in that discussion, because it's an absolute standard that we should maintain. An adequate blood pressure, and therefore we hope by default of that an adequate circulation. Yeah. So if we could at least hit the 65, that'd be nice. That would be a nice starting point.
30%, don't.
Well, it's not just a little bit of below 65. Right. It's
15 minutes,
quarter of an hour.
Yeah.
In ambulatory surgery centers, it's about 15 minutes. In the general cohort, it was over half an hour per case.
Yeah. And if you have a 2-hour case,
right. and then we're talking about the 65, which is the bare minimum. Ideally, we should try to aim for 70 or maybe 75 to just not get into that danger zone. But we're only counting the cases that dip below 65. So we're already at a place where we shouldn't be there.
So, Anna, we're talking about where we're going in the future. I think to this point, some of the things that we can look at in this cohort that we have is when the hypotension occurs and how much and when it is. So tell me a little bit more about that.
That's right. Yeah. So that's our next line of work is we're going to be focusing exactly on that question. When does the hypotension occur during the case? Is it happening around the time of induction? Is it happening during the surgery? And that obviously has great implications for what types of quality improvement strategies you would use to reduce hypotension. And then we're also looking a little bit at if the hypotension is concentrated or dispersed throughout the case. And because the outcome measure we're looking at is whether the patient has a MAP below 65 for at least 15 minutes. One of the questions we often get is that 15 minutes all at once? Is it 1 minute here, 1 minute here for a 2-hour case? And so we're doing some data visualization to actually look at those patterns. And then when we move on to phase 2 of our project and have patient outcomes, what we really ultimately want to know is, does it matter in terms of patient harm? Does it matter when the hypotension occurs, or is it harmful for patients regardless of when it occurs and how concentrated the hypotension is?
The way we looked at the data was more so to filter out what the providers were doing and if everything else were the same.
Yeah.
So if you got the same case mix, as a provider, are you doing close to average, better than average, or worse than average? One of the interesting questions was, we can also look at this from the perspective of a patient. So this patient, everything else kept constant. Are they more likely to get hypotensive or not based on everything else?
Yeah.
So that's something that would be interesting to look into, probably around phase 2.5, I would say.
That may be down there. There are folks looking at.
There are, and it does look as though there's some data suggesting that there is a, as we call it, phenotype. In other words, a type of person that's more likely to drop their pressure independent of overt disease states and or drugs they're taking.
Right.
The other question that came out I thought was intriguing was, there was, if anything, was more hypotension in ambulatory surgery centers in lower risk patients. And we recognize the fact that there's different types of anesthetics, broadly speaking, that we tend to use in the two places. And is that one of the variables that we're not accounting for? Which is a great question.
That is a great question.
Yeah. And then regional anesthesia versus propofol only.
And if it's general, whether it's gas general, Viva general, there are a lot of interesting questions that can be answered with time. But we do need to.
The last one that I thought was really good too was one of the gentlemen asked if we looked at if we were taking care of the same patients. And it was a provider that took care of them the first time that they were there, or the second time. People would think of joints. If you have the right leg done, then you're going to have the left leg done. We haven't looked at that, but I thought that was really interesting.
It is interesting.
Yeah, can be good. All right, guys. Well, thank you so much for joining us on TopMedTalk. I look forward to having further conversations as we get into the 2.0, 3.0, 4.0.
And just a teaser, without going to the details, you have started to do something about it. So don't tell us. We recorded something earlier, so you can add a link to that show note. You've started to...
We started to look into it a little bit deeper.
Skipped a little. We might have skipped a couple phases.
We did.
But
we look forward to hearing those results.
Yeah, well, we'll let you know.
Those should be up and coming soon.
That's right. Wael, it's going to be hard. Add it to the list, Wael. All right. Thanks for listening to TopMedTalk. You can find us on all your favorite podcatchers, social media platforms, and at TopMedTalk.com. Cheers. Thanks, guys.
Thanks for having me.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.